Hello, everyone, and we've got a big crowd out there today. And welcome to Innovation and the Future of Heart Valve Disease Treatment. This is obviously a hugely interesting topic. We have more than 600 people who registered for this webinar, so we're thrilled about that. My name is Lisa Tate, and I am serving as Interim Executive Director for Heart Valve Voice. I was one of the people who helped found the organization. I've served on the board, and now for an interim period, I am serving as Executive Director, and I could not be more thrilled to be doing that. Just a little bit about Heart Valve Voice. We are the only patient-led organization in the country that is exclusively focused on improving diagnosis, treatment, and management of heart disease. Some of the ways we do this are that we provide a voice for heart valve patients to improve access to the right treatment at the right time. We also raise awareness of symptoms and severity of heart disease or heart valve disease, and we do that particularly in at-risk and underserved populations who are very significantly underdiagnosed in this country. We also educate patients like we're doing today so that you can partner with your physicians in decision making regarding your care. And we advocate for policy changes to ensure optimal treatment of heart valve disease. So just a couple of examples. Some of you were involved recently in the Medicare decision regarding how TAVR would be provided in institutions and hospitals around the country. We as a patient organization advocated for wide access to TAVR. And that's just one example. When things come up in Medicare, we are going to be there for you advocating, and we want you to join in our efforts. Another example is in terms of its funding for NIH. The institute that works on valve disease at NIH is called the National Heart, Lung, and Blood Institute. So funding for that, for NIH and that particular institute, again, is extremely important to you and important to us. So we will also draw you in and hope to activate many of you to reach out and push policymakers to provide additional funding for NIH and NHLBI. And we also partner with other organizations to encourage them to focus on heart valve disease. For us, this is our sole focus. But for you'll see all of these organizations up here, obviously they've got a wide focus, but we are working with them and educating them and their constituents about heart valve disease, and then they are educating others. So we're really pleased that we've been able to build this big coalition to work and focus on heart valve disease. So that's it for me. I'm going to turn it over to Susan Strong. She is Director of Communications and Patient Engagement for Heart Valve Voice. She is a patient, and she also serves as an American Heart Association valve ambassador and is also actively involved in patient stakeholder and clinical research. So Susan, take it away.
Okay, thanks, Lisa. And our thanks also to Edwards Life Sciences for sponsoring this educational patient webinar series. Thank you. And we are so honored today to have two highly esteemed physicians presenting. Dr. Joe Cleveland, who's a cardiothoracic surgeon and professor of surgery at the University of Colorado Medical School, and Dr. John Messenger, interventional cardiologist and professor of medicine, also at the University of Colorado Medical School. I personally am extremely lucky that both of these outstanding physicians were in the hybrid OR with me almost 5 years ago when my aortic valve was replaced via TAVR. So Dr. Cleveland and Dr. Messenger, thank you for generously giving of your time today to share important information with patients. And Dr. Messenger, I understand you're going to start, so I'll turn it over to you now.
Well, terrific. Thanks, Susan, and thanks, Lisa, for such a kind introduction. Joe and I have had the pleasure of working together for the last 20-plus years, and it's been great, and we're thrilled to be here today. So today we're going to kind of go over innovations in the future of valve disease treatment. Dr. Cleveland and I are going to highlight some of these different areas that are affecting the aortic valve, the mitral valve, tricuspid valve, and kind of give you a peek into where we're going in the next 3 to 5 years in terms of that. So if you can go to the next slide, please. We do have some disclosures in that the University of Colorado does get research support from Philips Medical Systems, Edwards, Medtronic, and Abbott. That Dr. Cleveland and I are involved in research with all of these companies. Next slide. So I'm going to give a brief update on transcatheter aortic valve replacement. This is an area, obviously, of FDA approval, but really go into not only where do we stand in 2019, but what are some of the emerging indications. Dr. Cleveland is going to give us an update on mitral valve technologies, go over the MitraClip, which is currently has FDA approval in some indications, but also focus on some of the exciting areas we're going with mitral valve repair and replacement. Briefly finish up with some of the emerging tricuspid valve therapies, and really the key to this webinar is really to open this up for a nice discussion and dialogue, so hopefully we'll save most of the time for that. Next slide, please. So the background, surgical valve replacement really has been the gold standard since the first valve was replaced in 1960s. The most recent data we have, there was about 48,000 patients who underwent surgical mitral and aortic valve replacement in the United States in 2011. And this is from the database that collects information on patients undergoing surgery at more than 95% of the hospitals in the United States. The mortality rates for surgical valve replacement at the time in 2016, when we actually had access to the use of transcatheter aortic valve for the sickest of the sick, really were quite acceptable, with 2% for aortic valve replacement. The mortality for mitral valve surgery is about double that of aortic valve surgery due to the complexities, and hopefully Dr. Cleveland will touch on that, but that's about 4.4%. And these are in low to moderate risk patients. One of the challenges that we face is that as our population ages, they have far more conditions that make them high risk: diabetes, prior stroke, peripheral arterial disease, and lung disease, such that the overall surgical risk of the patient population is increasing. Next slide, please. And importantly, those patients that are age greater than 65 and age greater than 85 are actually increasing at a very, very rapid pace. There's going to be about 8 million people over the age of 85. This has doubled since 2000, between 2000 and 2030. And those greater than age 65 is increasing from 35 million in 2000 to over 70 million. So again, a doubling over only 30 years. And this is a group of patients that obviously is of interest to all of us. Next slide. The reason that they're of interest to all of us is that this is the inflection of valvular heart disease. This is data that are from large observational studies, the Aortic, the Cardia study, looking at the prevalence of valvular heart disease. And what you notice is that the prevalence of moderate or severe valve disease is quite low until patients are about 64. And then at 65, there's a significant increase in the population of overall valve disease. Mitral valve disease is about threefold more common than aortic valve disease, but all of these increase over age 65, and certainly if we were to show a graph, if we had data out to 85 and 90, these curves would continue to have marked increases in the prevalence of this. So valvular heart disease is really something that we're seeing more and more of as people live well and age into their 80s, 90s, and early 100s. Next slide. Aortic stenosis comes in a variety of flavors. Some people can be born with congenitally abnormal valves. We're not really going to talk about that today, other than to say that bicuspid valves is a variant of that. Rheumatic fever, which was very prevalent in the 30s, 40s, and 50s, set up inflammation and damage to the valves that led to early degeneration of those valves. Bicuspid valves, because of their abnormal way that they deal with pressure through the valve, degenerate at relatively younger ages. But the thing that we see the most of is what's called degenerative calcified aortic stenosis. This is really wear and tear aging, and most of the patients present with this in their 70s and 80s. Bicuspid valves usually present in their 50s and 60s when people become symptomatic. But this is a large spectra of diseases that we're trying to treat with a transcatheter heart valve and surgery in these patient populations. Next. There's a lot of factors, and probably too numerous to go into, that increase a patient's risk for surgical aortic valve replacement. We break these into clinical, anatomic, and then some of what we call non-traditional risk factors. The clinical ones are those of having had a prior open heart surgery. Women are higher risk than men. Obviously, kidney dysfunction, diabetes, severe lung disease, and heart failure, all of these are things that increase surgical risk. There are some anatomic things that can make young people prone to high-risk surgeries, what we call porcelain aorta or calcification of the aorta that can interfere with Dr. Cleveland's ability to cross-clamp and operate on an aorta, are things that oftentimes are induced by prior chest radiation from either breast cancer or Hodgkin's. Previous open heart surgery with open grafts underneath the sternum, or people who've had previous surgery, can be anatomical subsets of patients that otherwise are low risk for TAVR, but can be hard to reoperate on through a standard sternotomy. And then we're learning a lot more about non-traditional risk factors, that of frailty. Frailty measures including difficulty walking, poor grip strength, and reduced albumin with malnutrition markedly increase mortality for open heart surgery. And then we have other things that are of concern that we don't capture traditionally, of cirrhosis or pulmonary hypertension. But these are things that really drive us towards transcatheter valve therapies because of their increased surgical risk. Next. In the United States, we actually have FDA approval for a large proportion of patients that have aortic stenosis. We initially started off with inoperable patients back in 2005, 2006. We did randomized trials in high-risk and intermediate-risk patients comparing surgery to transcatheter valve therapy for aortic stenosis, and that demonstrated that TAVR was safer than open heart surgery and led to FDA approval in patients that were intermediate and high risk. And we've completed some low-risk trials that we'll go into a little bit that really capture the remainder of patients who undergo traditional open heart surgery in the United States. Next slide. Two recent clinical trials that have been published in 2019 were the low-risk trials looking at the PARTNER 3 trial with the Edwards balloon expandable valve and the low-risk trial with the Medtronic self-expanding valve. And these were randomized trials where patients were allocated by chance to either open heart surgery with surgical valve replacement or transcatheter valve with the two different valves that were under investigation at the time. Next slide. In a surprise to us, since we participated in this, there were marked differences in favor of transcatheter heart valve in the low-risk population. This is the primary endpoint that was published in the New England Journal of Medicine paper by Dr. Mack and colleagues looking at the death, stroke, and rehospitalization. And what you see is that there was about a 50% reduction in death, stroke, or rehospitalization in patients who underwent transcatheter aortic valve replacement compared to those who underwent surgery, showing the superiority of this strategy in a low-risk population. Next slide. Looking at the Evolut Medtronic self-expanding stent, they also had a very similar primary endpoint in their trial, looking at death, stroke, and heart failure hospitalizations out to 1 year. And again, there was about a 45% reduction in the composite endpoint of this favoring transcatheter heart valve. So two different valve technologies compared in a randomized trial to surgery, both of them showing similar outcomes for this. At this juncture, next slide. At this juncture, we are currently waiting FDA approval for transcatheter heart valves for low-risk patients, and that would then become the sort of a standard approach for most patients being considered for aortic valve replacement in the United States, and we expect that to come imminently in the next few months. Just focusing a little bit on some studies that are underway. One question is many patients have severe valve disease identified, but they don't have symptoms that are attributable to the valve. They are getting along in their daily lives without any complications. They don't feel limited, and they've not had hospitalizations. But what we do know is sometimes intervening on those patients earlier prior to them having adverse events may be a way of preventing adverse events. So the early TAVR trial is a study looking at patients that we stratify them using a stress test, and then are either following them or they're being randomized to transcatheter heart valve. So what we're basically doing is looking at the impact of early intervention on outcomes compared to natural history of continuing to follow them clinically. Next slide. In addition, there are many patients who actually have moderate aortic stenosis, but have significant underlying heart muscle dysfunction that oftentimes seems out of proportion to the effects of the valve. And the TAVR Unload trial is looking at patients who are treated medically with medications to optimize heart muscle function compared to patients undergoing transcatheter heart valve replacement and medical therapy, looking at whether or not people with moderate aortic stenosis might benefit from reducing the obstruction of blood flow out of failing heart pumping chambers. And that's another trial that is ongoing, looking at expansion of the indications for transcatheter heart valve. Next slide. Finally, we've focused on aortic stenosis, but many people, instead of having valves that obstruct blood flow, have leaky valves that allow blood to flow backwards into the pumping chamber. The causes of this are very different than the narrowing of the aortic valve. And what we found is when we've used the current generation devices in those patients who have leaky aortic valves, we don't get the same results that we get in patients with narrowed heart valves. And that's because these valves tend to be bigger. They tend to be associated with more complications of implanting a valve stably. Next slide. As a result, there are dedicated valve designs that have been investigated, and there are ongoing investigations looking at native valve leakiness. These valves have very novel designs where they basically sit into the aortic valve and actually adhere to the valve through clamps that work very differently than the current valves. And these studies, this valve has been approved by CE mark in Europe and is now undergoing early clinical trials in the United States that should expand the population of patients that might be amenable to being treated with a transcatheter heart valve. Next slide. So I'm going to turn this over. I've done enough talking here to Dr. Joseph Cleveland, my surgical colleague.
Thanks, John, and actually that's a great segue because we'll now move to the mitral valve, and again, just for kind of an overall view, John's talked about the aortic valve, which is kind of the last valve, if you will, in the heart before blood leaves the heart to go to the rest of the body. So immediately upstream from that valve, if you will, is the mitral valve, which is the valve that separates the collecting chamber, the atrium, and the left side of the pumping chamber from the ventricle, the pumping chamber, and it's a very complex structure. Next slide, please. As depicted here, mitral valve disease, first of all, unlike the aortic valve, the mitral valve has really a component of, if you will, a relationship that's not only leaflet-based, but there are these delicate structures that look like parachute cords or parachute strings cords attached to the ventricle. So we'll talk about causes of mitral valve disease. Now, just like aortic valves, mitral valves can become narrowed with mitral stenosis and mitral regurgitation from things like rheumatic fever. But even more commonly, we see a lot of mitral valve disease when you look at the bottom of the slide, when you go from a normal mitral valve to a mitral valve that leaks or is regurgitant. And there are two forms of that. There's so-called degenerative mitral valve disease, where the valve itself is abnormal, and it's usually due to excess mitral valve tissue, degeneration of the mitral valve tissue. That is where the valve actually leaks because the valve's not normal. So-called secondary or functional mitral valve regurgitation is because of a sick heart muscle. So in other words, in this scenario, the heart muscle gets sick, the heart then dilates, it becomes big, and it goes from a shape kind of like a football to a basketball. And in so doing, the attachments to the mitral valve get displaced. And so just like a set of French doors where the frame gets pulled apart and the doors can't close, that's kind of analogous to what happens to the valve. And this is important to understand some of the treatment paradigms we'll talk about shortly. Next slide, please. So as Dr. Messenger already pointed out, mitral valve disease is actually increasing faster than the aortic valve disease. When one looks at the prevalence, that is, how many people have this disease, threefold, as Dr. Messenger said. taken from population-based studies. And again, the inflection point, as Dr. Messer points out, is somewhere in our mid-60s when we start to see a lot of degenerative changes happen in the mitral valve. These are also changes, these are also when people also are at risk for things like heart failure to develop from a variety of causes, from either ischemic causes, like people having repetitive heart attacks or things like that, where the heart then goes on to dilate and makes the mitral valve not work as well. Next slide. So, as Dr. Messer pointed out, operative risk for mitral valve replacement is about double that of aortic valve replacement, and it is because it is more complicated. Replacing mitral valve does engender a different kind of set of circumstances. The mitral valve, for one thing, is placed in the back of the heart, so it's a little harder to access than the aortic valve. Secondly, as I mentioned, the mitral valve has a very important relationship to the heart muscle function, and sometimes a leaky mitral valve will uncover the fact that even when we repair that, the heart muscle function has become deranged significantly. That is, it's become impaired. And when we repair that mitral valve or replace it, now the heart starts to struggle because instead of being able to eject that blood backwards and forwards with a competent, that is a non-leaky mitral valve, it has only one way for blood to leave the heart, and that's to go forward. And that can sometimes uncover the fact that the heart muscle has gotten sick. And then lastly, as Dr. Messer points out, as we point out on the slide, patients with what so-called functional mitral valve regurgitation usually do not get good outcomes of surgical mitral valve repair or replacement. It's been examined, and it turns out, again, operating on these patients, it's kind of like doing something to the mitral valve when it's really the heart muscle that's sick. And so these patients don't tend to do well without advanced therapies like sometimes left ventricular assist devices, heart transplantation, as well as other medical therapies for their heart failure. So while you're attacking the mitral valve and fixing the leakage there, you're not addressing the underlying problem, which is the failing heart muscle, and a lot of times patients don't do well after surgery for that, and we'll talk about some alternatives for that shortly. Next slide. So a very creative Italian surgeon, Otero Alfieri, created a very simple repair for a mitral valve, where he put the front and the back leaflet together right in the middle, sewed them together with a suture, and created kind of, if you will, a double orifice for the mitral valve. This was done to prevent leakage of the valve, and it was very good at doing this. A single suture in the center created a double orifice. He published this and presented it, and I have to say, like many new things to surgeons, initially he wasn't accepted. It was kind of like, well, this seems too simple, et cetera, but we learned over time this was a durable way of repairing mitral valves, and some bright engineers from the Bay Area actually developed a therapy, excuse me, that we'll talk about called the MitraClip, based on this therapy, which was basically an edge-to-edge repair. And they said, well, gosh, rather than opening somebody up, can we not do this percutaneously? And lo and behold, next slide, it can be done percutaneously. So we'll talk about the treatment of functional mitral regurgitation. To back all the way up, the treatment of degenerative mitral valve disease with what's called a MitraClip, and we'll show a picture of that in a little bit, a percutaneous clip that simulates that Alfieri approach, was studied through the 2005 to 2010, 2012 era, and proven to be as good as surgery, or I should say less invasive than surgery, to reduce blood transfusions, but actually not to reduce the mitral regurgitation as well as surgery. So for degenerative mitral valve patients who are extremely high risk for surgery, the FDA said it's okay to use the MitraClip, but for patients that are low risk for surgery, they should have an open mitral valve repair because that's still so much better. As I mentioned, for functional mitral valve, that's where the ventricle is sick and the mitral valve is kind of the innocent bystander. We didn't really have a good therapy. So the COAPT trial was a trial that was done where we compared patients, 614 patients that actually were randomized, that is, coin was flipped, and patients were placed on guideline-directed medical therapy, that is, optimal medications. They were given pacemakers if they needed them, and then at that point they either got a MitraClip to treat the mitral regurgitation or they continued on medical therapy. Next slide. And the results of this were published last year, presented at the Transcatheter Therapeutics TCT meeting, and then published subsequently in the New England Journal of Medicine. And what was shown here was in the guideline therapy alone group, that is without treatment of the mitral valve with the MitraClip, a much higher rate of hospitalization. So the addition of the mitral valve, or the addition of the MitraClip 2 guideline-directed medical therapy halved the rate of hospitalizations for heart failure. Not shown are data also, the secondary endpoint, that it also reduced mortality by about 30%. So patients were out of the hospital with feeling better and alive based on these data. So this is the first treatment of functional mitral regurgitation that's actually been positive with the device, and it's with the MitraClip device. Next slide, please. So shown here are the current kind of investigational devices as well as the MitraClip. So the MitraClip is shown in the upper left. Again, it almost looks like a little clothespin, and there is now a newer, improved version of the MitraClip that's ongoing in the United States. And again, this device clips on to the leaflets of the mitral valve to basically put them together much as though the Alfieri stitch did. The Carolyn annuloplasty device is an investigational system that can be placed percutaneously, looking to shrink down the opening of the mitral valve to see if that can reapproximate the French doors, if you will, kind of bring the frame back together. The Cardioband system from Edwards is also undergoing treatment, similar concept. The Millipede annuloplasty system, shown in the lower right, is also investigational and ongoing feasibility studies. And lastly, the Pascal device shown here, Edwards device, is now undergoing treatment as well in comparison to the MitraClip. It's basically another version of the MitraClip. Different manufacturer, has some advantages and might work differently than the MitraClip. Next slide, please. So again, the class clinical trial is the Edwards Pascal device. This is a screenshot of the clinicaltrials.gov, and I encourage anybody that has questions about this to seek the clinicaltrials.gov website to look at these investigation devices. They include things such as what type of patients are being enrolled, who are not candidates for the enrollment, and have some contacts for if you want to reach out to the study sponsors to find out where is this device being, or where are these trials being conducted, particularly vis-a-vis where people might live and be next to these centers. So this shows the Pascal device, again, taking the front and back leaflet of the mitral valve, cinching them together in the middle of the valve, and creating, again, this double valve orifice. Next slide, please. Similarly, the Cardioband trial under device. In this trial, this shows actually a hole that is being created where the device is brought up through the vein in the leg, steered across the wall between the right and left atrium, and then placed in the left atrium where the mitral valve lives, and secured into place. Next slide, please. Lastly, we also have transcatheter mitral valve replacements that are investigational. So there are some patients that have such severe regurgitation and such severe anatomic abnormalities that a simple clip or a simple annuloplasty, that is remodeling thing like the Cardioband, won't work. And so we actually have a series of valves that are transapical on your upper left, Tendyne, the Intrepid, Medtronic, Tiara, Neovasc, and transfemoral devices, CardiaQ, HighLife, and Castion, that are now undergoing investigation in the United States. Next slide, please. As pointed out here, Dr. Messenger, I wish to also illustrate that one of the anatomic challenges facing transcatheter valve mitral replacement is the relationship of the mitral valve to other structures in the heart. And so there are two relationships that are very important. One is on the back side of the mitral valve sits things such as the circumflex coronary artery. So that can be obstructed by these large devices. If you will, on the top side or the front side of it sits the aortic valve. And one of the very key features is that we can actually obstruct flow, believe it or not, out the aortic valve if too large of a device is placed in that mitral valve, or the front leaflet of the mitral valve impedes into what we call the left ventricular outflow tract. And that's shown on the right side of the slide, where device size, geometry of what's called the mitral anus can definitely impact how these devices work and what the new or neo left ventricular outflow tract is. And so these are very important considerations. Thus, a lot of time is spent, and as is in the transcatheter aortic valve world, a great deal of imaging, both echocardiograms, CT guided, is done before we can place these devices to ensure people are candidates. Next slide. So there are some technical challenges, and we're certainly, the transcatheter mitral space is not leaping ahead quite as quickly as the transaortic is, and that's partially because of some of these challenges. One, the generation delivery systems are very large. They're 30 in excess of 30 French for the transapical route right now. Those are large holes that have to be surgically repaired right now, with the exception of one of the devices that has its own plug that comes with it. As we mentioned, there are different complications in transcatheter aortic valve and TAVR, obstruction of blood flow out of the heart through the left ventricular outflow tract, conduction system abnormalities, that is pacemaker need and circumflex artery obstruction, impact on the LV function. As we mentioned, the mitral valve and the left ventricle share a very important relationship. And then lastly, prosthetic valve related events, clotting the valve, thrombosis, infection, valve being moved that is embolized, and also leak around the valve, and also the challenges of ongoing anticoagulation. So these are some of the things that really are going to have to be answered in these clinical trials as we move forward before we can really have some of the same confidence that we've had that transcatheter mitral valve will have the success that TAVR will. I'm confident we'll be able to conquer these challenges, but yet it will take time and proof of concept. Next slide. So the last device trial I mentioned, the Tendyne Summit trial, ongoing as well. Again, clinicaltrials.gov web shot. The Tendyne valve is shown here. It's a very large kind of prosthetic valve. What's shown is actually the view that blood would have going from the atrium into the ventricle through the valve. And at the kind of left-hand side of that is a plug that goes in the apex, where again, this is access, or this valve is placed by making a hole in the apex, or the tip of the heart. Valve is then placed through a large catheter delivery system in the mitral valve, and that hole is then plugged, and a tension is adjusted on that valve so it works correctly with that little plug. I think that, next slide, I think with this we'll turn it back over to Dr. Messenger to briefly discuss tricuspid valve disease, and then we'll take questions.
The tricuspid valve disease, thanks Joe, is the valve that controls blood flow between the right atrium and the right ventricle, and people have talked about this as being the forgotten valve. People do well, it's oftentimes quite leaky. Surgery on this valve, because of the low flow state on the right side of the heart, because the pressures are so low, is associated with complications of valve replacement. And operating on the right ventricle is associated with much higher operative mortalities than mitral valve surgery and aortic valve surgery. You can see even up until 2010, operative mortality is almost 1 out of 11 patients. So obviously, surgery for this was really something we reserve as the last resort. Next slide. The tricuspid valve is a little bit more complex, but tricuspid valve procedures in the light blue at the top are actually increasing. They've actually doubled over the last decade. The tricuspid valve actually has to deal with the pressure that's increased in the lung arteries related to leaky mitral and aortic valves, or stenotic mitral and aortic valve. And so we're seeing a lot more of it in this era as valve disease is increasing. Next slide. There are some unique approaches being used in the mitral space. We're trying to adapt devices that, much like the MitraClip devices, where we can clip these leaflets. The problem with the tricuspid valve is it has 3 leaflets instead of 2, and so getting these clips on 2 leaflets can be a little bit of a challenge from an imaging perspective. There have been devices that fill space, like this balloon in the top left from Medtronic, where basically we fill the orifice with a balloon that doesn't obstruct flow. That's one approach. We've tried using transcatheter heart valves to limit blood flow or improve blood flow through the right side of the heart. We've tried to replace the tricuspid valve with transcatheters. All of these are in their relative infancy and are really an area of explosion going forward. Next slide. As I mentioned, these clips are sort of things that are right now what are under most investigations, as well as the cardioband that Dr. Cleveland talked about. Instead of going across the interatrial septum, we can utilize that to cinch down the outer ring of the tricuspid valve to make it such that the leaflets are more effective at closing. All of these things right now are under investigational study in the United States. Next slide. So to conclude, TAVR is currently FDA approved for the treatment of inoperable, high-risk, and intermediate-risk patients with symptomatic aortic stenosis. This includes treatment of failed bioprosthetic valves, as well as patients with bicuspid aortic valves. Transcatheter aortic valve replacement has been demonstrated to be equivalent or superior to surgical valves in low surgical risk patients, and we expect FDA approval soon. We're evaluating it now in asymptomatic patients that have severe AS, in moderate aortic stenosis with impaired heart muscle function, and also leaky valves. And we also have a whole host of next generation valve technologies to try to improve the performance of the procedure, but also the durability. Next slide.
Yeah, so for the mitral valve, the repair replacement timeline, I think, will be much longer than TAVR due to the complexity of this valve, as we talked about. Currently, the transcatheter mitral valve repair with MitraClip is only FDA approved for high surgical risk patients. Those are patients that have an STS, that is Society of Thoracic Surgeons, calculated operative risk of greater than 8%, or seen with a heart surgeon and the heart team and estimated to be at high risk for other reasons with degenerative mitral valve regurgitation. The COAPT trial that I mentioned is established superiority of MitraClip plus guideline-directed medical therapy to guideline-directed medical therapy alone in patients with functional MR, that is heart failure, the valve is failing because the heart is big and failing. We expect FDA approval soon. Again, like a lot of these therapies, the data is sitting with the FDA, and again, when this approval comes, should be hopefully within this calendar year. Transcatheter mitral valve replacement repair has many promising technologies, and there are many first-in-human studies underway in the United States, a lot of clinical trials undergoing. And then lastly, John.
Yeah, obviously the tricuspid valve approaches are in their infancy, but I think are moving forward quite quickly. I think the tricuspid valve will act similarly in terms of technological advancement to the mitral valve. Both of these valves are very different in that they have important interactions with the heart valve, or with the heart muscle underlying them, and they're more complex than the aortic valve. Next slide. So at this time, we'd love to open it up for a panel discussion, questions, and we'll turn it back to you, Susan and Lisa.
Thank you so much for your time for this. Sorry, I had a little problem with my mute button. We had lots of people asking questions, and we had, I would say, 3 primary categories that the questions fall under. I'll tell you the 3 categories and then ask a few questions depending on the time that we have. One question is, what are the signs that my replacement valve is failing? Like, how will I know when it's time to pay attention to symptoms or things that are happening that I might need a valve replacement? Other questions that were asked multiple times centered around durability of valves, of how long can we expect valves to last, replacement valves? And then some questions about valve-in-valve procedures. So is there one of those topics that you'd like to start with first, or
sure.
Should I ask? Okay.
Dr. Cleveland, and I'll address the first question, which is, I guess, when do I, or how do I know my implanted surgical valve is failing? And in general, it is a recurrence of some of the original symptoms, particularly breathlessness or having a hard time breathing, particularly with exertion, is the most common sign for a failing both aortic and mitral prosthesis. Again, basically, people go back into early stages of heart failure. Those early stages being congestion with fluid retention and things like that. Obviously, as Dr. Messenger and I would advocate, anybody that's had a heart valve replacement should have yearly examinations and see a cardiologist yearly, have echocardiograms to track these valves. And certainly one of the things that can be looked at those echocardiograms is the structure and the function of that valve, particularly vis-a-vis measuring pressure gradients or pressures across that valve. And if you will, it can be tracked. And as the valve typically the valves will get thickened, calcified, and kind of fail by stenosis, but occasionally they will fail by leaking. And that sometimes tends to be not a absolute, like, sudden this date at this time, but sometimes more of a precipitous, faster set of symptoms. If one of those leaflets will actually, they don't completely tear away, but what they usually do is they become disrupted to such that the valve goes from being, say, mildly leaky to severely leaky in a matter of days, and sometimes that will precipitate an acute presentation with heart failure. So I'd say again, to sum up, heart failure as manifested by troubles breathing, particularly when you are trying to do things like climb up a flight of stairs, do anything, even walk up a ramp carrying a bag behind you or something where you got to do a little bit more work. John, anything else to add?
No, I think that summarizes it. I think paying attention to how you feel, fatigue, while very present in most patients, usually we do see mostly patients having shortness of breath or chest discomfort, chest tightness and shortness of breath together are the manifest of that. In terms of, Susan, just following up on the valve and valve, the reoperation for a second time carries about double the risk of a first operation. And so many patients, by the time they're being reoperated, are much older and have more comorbid conditions. The FDA allowed us to use data from our clinical registries where many patients received transcatheter valves within failing bioprosthetic valves, not mechanical valves, but bioprosthetic valves that were either cow or pig valves. And we were able to demonstrate safety of doing that. The long-term outcomes of valve and valve are not yet clearly delineated. We think that they are going to function very similarly to TAVR outcomes in other locations. It's important to note that treating aortic valves is very different than treating mitral valves. Mitral valves have very low pressure gradients between the left atrium, where the pressures are very low, and the pumping chamber, the left ventricle. And we do need to treat all patients who receive transcatheter heart valves in that location with anticoagulation, because those leaflets will clot and thicken and fail early. In the aortic valve, the blood flow velocity and pressures are much higher, the valve's being washed with each time the heart beats. So we don't have the same need to treat those valves with anticoagulation. So right now, our approach is to treat most of these patients with transcatheter heart valves for their failed bioprostheses, but we don't have good data on long-term outcomes in those. And I think there was one other question you had that we may not have addressed.
Yeah.
Yes, I'll follow up with that. And I guess just to summarize too, on this particular question for patients, I'm hearing that the takeaway for patients is that it's very important to maintain that yearly follow-up after a valve replacement, and then also if they're, and to have echocardiogram at that time, and then to follow up outside of that year if they're noticing symptoms, perhaps symptoms that were similar to what they had prior to the first valve replacement of shortness of breath, fatigue, tightness in the chest, those kinds of things. Is that the main takeaway for patients on this one?
Yep, and
Absolutely.
Okay, great. And then we had a question too, just about a vocabulary. Percutaneous was used several times. And could you just explain in lay terms what that means?
Sure. So when we talk about open heart surgery, that usually is done through cutting the breastbone, Dr. Cleveland, cutting the sternum and opening the chest cavity to get access to the heart. When we talk about percutaneous or transcatheter, we usually are talking about working through the blood vessels and approaching the valve from the inside of the large vessels so that we can replace the valve from inside. And so it really is a less invasive approach to treating that. With that said, sometimes we go through catheters through the tip of the heart, which, is a little bit more invasive than going through the leg arteries. That's required in some patients due to anatomical considerations. But the big key is true percutaneous procedures result in far less morbidity. People have faster recovery and have less risk of infection around the time of the surgeries and are quicker to get out of the hospital.
Okay, and then another question, you reviewed 3 of the 4 valves in the heart. Are there transcatheter valves available for pulmonic repair or replacement?
Yeah, so in the interest of time trying to get through this, we didn't mean to, shortchange the pulmonic valve, but the pulmonic valve is one that's really a congenitally diseased valve in most cases. Most people are born with congenital heart disease that results in malformation of the pulmonic valve. And so current treatments for that usually involve putting a valve within a previous valve. There are two FDA-approved valves for that. The Melody valve by Medtronic is the most widely implanted and investigated valve, where it's a valve very similar to the Evolut valve, where it's a valve within a metal scaffolding that is put in through a catheter into the pulmonary valve, and that provides a competent valve. And then the Edwards Sapien XT valve has also received FDA approval for balloon expandable valve within these valves. Usually they're failed bioprosthetic valves, or what we call homografts, that are basically surgically replaced valves that we're using as the scaffolding to put these stents in. But both of those are used and used quite frequently. Most of these are done at pediatric or children's hospitals because that patient population tends to be younger or under the care of experts treating adult congenital heart disease.
Okay, thank you. And a follow-up question about the durability again. Is there any difference between surgically implanted valves and the minimally invasive valves in terms of durability? Do we know that?
We do not know that. We expect, so what we have data for about 10 years on the, a little longer actually, 10, 12 years when you look at the European data for the transcatheter percutaneous valves. And there has been published data for both the Edwards and the Medtronic valve at 5 years. And those data suggest that there's no signal that there's any difference in the way the percutaneous valve behaves compared to a tissue surgical valve. Remember, all surgical valves that are tissue-based last between 8 to 15 years. That's kind of the range, and 15 is the long, and we all expect when we put in a valve that we want to be, you know, a patient that gets the long, but the average is about 8 to 10 to maybe 12 years. So short answer is we don't have any data to suggest that the percutaneous valves will last shorter, nor do we have any data to suggest they'll last longer. They'll probably behave about like the surgical valves we implant right now. I don't know if Dr. Mestre has anything else to add.
And these are technologies, you know, there really are the same valve leaflets that have been placed within stents that we can put in through the blood vessels. So, you know, the technology, the materials are quite similar to the bioprosthetic valves.
Okay, and just to clarify too, for patients, a lot of patients use the term tissue valve, and I'm assuming that tissue valve and bioprosthetic valve are the same?
Correct. They're the same,
Okay.
That's right. It's a valve from either a pig or a cow, as opposed to a mechanical valve that's a metallic heart valve.
Right, and the mechanical valves cannot be done with a catheter, correct? It's
That's
only
correct.
the tissue
Correct.
valves.
You can't crimp, you cannot, at least to date, we've not figured out a way to put a mechanical heart valve and shrink it into a stent or into a catheter like we can on a stent like you can a tissue valve.
And the current mechanical valves have structures that preclude you from being able to deploy a valve inside of them.
Correct.
Based on their design. So the rate of use of mechanical valves has markedly decreased in the United States over the last 10 to 15 years because of people's awareness of transcatheter heart valves as a second option, or as an option if that valve fails. And so more and more people are getting bioprosthetic valves, particularly over the age of 50, which is the current guidelines for that.
Thank you. And then I have a question in kind of the cardio-oncology realm about younger patients like myself who might be survivors of childhood cancer or radiation treatment. And sometimes those patients get conflicting information when they're being evaluated for TAVR. Sometimes they're being told they're low risk, sometimes they're being told they're high risk. Can you speak to that? This is confusing for patients, and do you have a response to that? Thank you.
No, Susan, you bring up a great point. That was that point of that slide of the traditional risk factors and these sort of non-anatomic. You know, radiation is, you know, fantastic at helping us cure many types of cancer, but the long-term impact on the tissues around the radiated area can be significant. And so patients who have radiated hearts look all the world like their heart muscle function is normal by our typical measures of echocardiography. When those patients, though, are subjected to stress, in particular open heart surgery, the the scar tissue that forms as a result of the radiation results in abnormal responses to surgery, and those patients have far more surgical complications. And so even though they appear to be low risk, we know from the natural history of operating on them that their heart muscle reserve is impaired as a result of radiation. And from chemotherapies, many patients' heart muscles are impaired and they don't respond well to open heart surgery with the heart-lung machine, and we can oftentimes get them through with transcatheter heart valve replacement. Even in that setting, though, the hearts don't have a normal response to that stress and can sometimes pose some of our more challenging cases, even though the patients themselves look like they're very low risk otherwise, without significant other comorbid conditions.
Okay. And is there any, sorry, I'm getting things sent to me. Women who've had breast cancer, is there anything in particular concern about the radiation that they've received?
Not usually. That is a lower level radiation. It's usually targeted away from the heart. With the radiation that is really the toughest is certainly the radiation was done in the 70s and 80s for people that had Hodgkin's disease, particularly if they got full dose mantle radiation to their sternum, and a lot of radiation that way, because again that radiation was delivered to treat disease that was within the confines of the chest cavity where the heart lies. The radiation used for breast cancer is usually quite a bit smaller dose and is very targeted to the breast itself, and so that usually does not pose a risk for people.
Okay, thank you so much for clarifying that for our patients. We have a question too about, are antibiotics always necessary for dental procedures after having a valve replacement?
You want the party line, or so the official, and it was great that this comes up because I just had this discussion with a patient in clinic today. So my personal opinion is yes, strong yes. So the party line from guidelines and things like, and I'm not saying I'm smarter or at odds with societies like the infectious disease. I mean, so you can look upon it as a public health issue where you say for 100,000 people to treat these people, you actually risk engendering more adverse reactions to the antibiotics or getting bacteria that are resistant to the antibiotics. I say for a patient I've operated on, I have a relationship with that patient, and I don't care about the public health. I shouldn't say I don't care about public health. I do, but my care or my priority is much more shifted to my individual patients. So I recommend to all my patients who have had either aortic, mitral, or tricuspid or pulmonic valve replacement that they get antibiotics at the time of the dentist. That's not concordant with guidelines currently.
And in general, you know, there are lists of procedures that definitely need antibiotic prophylaxis. We're fairly aggressive in making sure that people have that discussion with every person that they're having a discussion about healthcare with, because everybody needs to know about, you know, these bioprosthetic valves in getting infected. Mechanical valves, obviously, it's a double issue of most of them are on anticoagulants that are also need to be navigated around the time of invasive procedures. So we are pretty aggressive with, you know, antibiotic prophylaxis with amoxicillin or clindamycin, and have patients take that, because endocarditis, if you were high risk for your initial valve such that you ended up with a transcatheter valve or a valve replacement, the second time having it done emergently for infection is far higher risk. And so we really like to try to avoid that.
Yes, thank you. And a follow-up question for that, what are the symptoms of endocarditis? Is there something as heart valve patients we should be just aware of in taking care of our own health?
It can be very difficult, to be honest with you. I mean, you know, the endocarditis is one of these things where it actually can present in a lot of different ways. So, you know, the full-blown, if you will, you know, if you read the textbook, is recurrent fevers, weight loss. People get very sick over a period of usually weeks. Now, there are some people that have, again, and part of this has to do with, there are a variety of different bacteria, funguses, other things that can create endocarditis. So endocarditis just really refers to inflammation and infection of a heart valve, or actually the lining of the heart valve and the heart itself. But I would say certainly anytime you have an unexplained fever for more than a couple of weeks, lethargy, later on you get rash on hands, you know, things like that. Those are the cardinal symptoms, but it can sometimes be very subtle. And so I told people, sometimes people are told they have the flu for 6 weeks. That kind of stuff doesn't make sense. So anything hangs around for more than a couple of weeks, I think, and particularly a murmur. If a murmur's heard that you've not heard before, then that should trigger a prompt workup. It's unfortunately, Dr. Messenger, I sometimes see people who are referred late, and it can sometimes just be because it can masquerade as a lot of things. It can sometimes masquerade as kind of, again, the flu for a couple of weeks, or just a lot of different things. I don't know, John,
Yeah.
what's your
No,
thoughts
very
are?
similar. I think, fevers, chills, weight loss, general malaise, those are generally the things that we see the most of.
Mm-hmm. Thank you.
Problem
And again,
where it's not specific, there's a lot of those things that can create, that's a lot of things. And so I'd say if you have that, you need to get checked out. So.
right. The takeaway for me as a patient is to be our own advocates and really pay attention to our bodies and not ignore symptoms that aren't normal.
Correct.
Exactly.
Another question, just about calcification, and someone asks about, is taking calcium supplementation, is there any risk in doing that? Sometimes, especially women are told to take calcium for bone density. Is there any contraindication with that with heart valve replacement patients?
No, no. So I'll just say, sorry, so you can hear me. No. The calcification that occurs when the heart valves, it's a process of degeneration of the valve, and the calcification is kind of the end stage of that degeneration. So it's not accelerated by exogenous calcium or things like that. There are certain subsets of patients, again, people with renal failure, that sometimes have abnormal calcium metabolism, where again, that might be a small group of people where maybe that, but that usually is regulated anyway with their renal disease, like dialysis and stuff like that. But for the general public, and particularly people that want to, take calcium, that's fine. It doesn't accelerate the demise of the heart valve, or it doesn't in any way contribute to the dysfunction of it.
Okay, we are down to the last 3 minutes. I'll ask one final question and then we'll close up. How do you feel about the future of heart valve disease treatment for patients? Are you optimistic, pessimistic? What would you say to patients who are kind of anxious about their futures?
I'm going to speak for Joe Cleveland. We're very excited. I think this is, from my time in medicine, being in medicine the last 25 years, this is the most exciting period ever. In 2010, Dr. Cleveland and I had never even thought of the concept of replacing a valve with a transcatheter heart valve. And fast forward 9 years, we're doing, we're probably changing the entire paradigm to transcatheter heart valve replacement for all patients with aortic stenosis. And we have mitral and tricuspid valves under investigation. So we are very excited. The technology that our partners in industry have brought to us is fantastic. The FDA and CMS have partnered with us for the first time to make the United States leaders in the world in terms of the mitral and tricuspid technology. So we are super excited about the next 5 to 10 years of transcatheter valve therapies.
I'll echo what John says. As a surgeon, people say, is this a threat to you? I say no. What this represents is a better way to deliver therapy. Obviously, it has to be tested, but I think it's been one of the most rigorously tested therapies, and the pace of innovation has been something that has been exciting for me to be part of too as well. It's also, I think, reunited specialties, interventional cardiology, cardiac surgery. We're doing so many things together these days to the benefit of our patients. So that's very exciting for me. I mean, John and I have always worked very well together, but again, it was never a thing of my therapy, his therapy. We were never one of those things, but it's just really fun that tomorrow we'll have 4 patients that we will treat with transcatheter aortic valve replacement, and I know that they will all benefit from this therapy, and it really does reinforce kind of one of the reasons that we were, very, I think, just fortunate to be involved in, cardiology, cardiac surgery at this time. It's exciting.
Well, thank you so much for being here and for answering questions. We weren't able to get to every single question. We will try to include some more information on our website when the webinar is posted, so look for that. And we also included a slide for patients. You had talked, Dr. Cleveland, about the clinicaltrials.gov, and so we wanted to include that again for patient reference. And then another website that I have found to be useful is called Antidote, and it fits over the clinicaltrials.gov and makes it a little more user-friendly, because that clinicaltrials.gov sometimes can be confusing or difficult to navigate for patients. So we will have those links available on our website as well. Next slide. So this concludes, like the bell's ringing, so this means that our webinar is concluding. Thank you again so much, Dr. Cleveland, Dr. Messenger, for generously giving your time to speak with patients today. I think this has been very helpful, and we hope you might do it again someday.
Terrific. Well, thanks, Susan, and thanks, Lisa, for including Dr. Cleveland and I. It's been a great honor.
Thank you very much.